Bismillah ar-Rahman ar-Rahim. My dear fellows, friends and students, previously I have talked about the pleura and the pleural membranes and the abnormalities in it. That is the collection of the fluid, whether in the form of the transudate or exudate or in the form of pus, that is called pneumothorax. Today I want to discuss another topic, which is pneumothorax. I am a facilitator and Professor Dr. Ali Haider, representing the Janaisin Medical University, and it is a presentation actually which I want to show you. It's made by my colleague, my friend, although thankful to him that because this part is actually important as far as surgery is concerned also. So it is a part of the pediatrics also. So internal medicine, pediatrics medicine, and the thoracic surgery and general surgery, covering this will cover this topic and the light of this. So the pneumothorax is the collection of the air in the air space, pleural space. Now, pleural space is a potential space in which hardly 1 ml fluid is circulating all over the lung. You know that about it. Anything which is entering alien inside it in the pleural space is abnormal, should be regarded as abnormal. If the air is entered into it, it is known as pneumothorax. If some of the transudate is also collecting along with the air, it is called the hydropneumothorax. If the collection is pussy in nature along with the air inside the pleural space, it is called pneumothorax. Actually, the thing is this: in the pure form, pneumothorax mostly is seen in the two forms. One is very commonly associated, you see in the motorcycle accidents and the accidents in your city, Karachi. Often there is a fracture of the ribs and leading to the traumatic pneumothorax. Second one is there is no associated incidence of any trauma. Without it is known as spontaneous pneumothorax. The trauma is a part of the surgery, and whatever the trauma which caused it and how the air is entering into it is actually the topic of surgery. So we do not comment on the traumatic one, because the treatment is definitely associated with the procedure which they do when there is a traumatic type of a pneumothorax. So this is the pneumothorax, the conception of the X-rays is concerned. You see, this is a view, it is a standing view, frontal projection. Here it is seen, there is absolute hypertranslucency is seen in this case, and here you will see there is a line, very grayish white line is going. This is the remnant part of the lung, right lung. This is called pleural white line, and this is the collection of the air, and it causes the pressure on this side. So the right side of the border is not visible, correct? It is not visible. And this is the remaining part of the lung. This is the pleural part which is adherent to it, which is here. And this is the trachea, which is not deviated in this case. Although the pressure, if it is more than that, it may be shifted to the other side. definition is this: the accumulation of the extrapulmonary air within the chest, most commonly from the leakage of the air from the lung into the pleural space. This is called the spontaneous pneumothorax. Now, spontaneous pneumothorax is actually of three types. Here it is written two types. One is open due to the disruption in the integrity of the chest wall and the parietal pleura. The rupture of this visceral pleura and is entering the air into the pleural space. Or it is the other way, there is a hole which is made by injury directly penetrating the chest wall and enter the environmental air into the pleural space. The closed type of the pneumothorax is the air entry into the pleural space by the disruption of the pulmonary parenchyma, which is adherent to the visceral pleura. So it makes a space or a hole or a foramen in this, and then the air enters into the pleural space. The third one is called, which is called what is known as the closed type and the open type, and the third one is also there. There is suction of the air inside, and it is during inspiration the air is entrapped, during expiration it is closed. So the third type is this. This one is the open, one is the closed, and one is the suction type of the pneumothorax, where the reverse of it, there is inside, if you inspire, the air will entrap into the pleural space. Now, etiology of the closed pneumothorax is the pulmonary diseases like foreign body and the respiratory distress syndrome can cause the disruption of the pulmonary parenchyma, respiratory infections like, for example, the acute inflammation of the lung, and the bronchial asthma, and there is a formation of a small bulla which ruptures. Cystic fibrosis will cause bronchiectasis or emphysema, and the cause is the same. And the chemical pneumonitis, the chemical injury to the pulmonary parenchyma can cause it. The diffuse lung disease will cause it, means it interstitial lung disease, and tumors which is communicating to the pleural space. It may be iatrogenic, like for example mechanical ventilation, you are going the central venous catheterization, the apex of the lung is in communication then with the pleural space. So this is the closed pneumothorax. Mainly it is the air which is entering from the pulmonary parenchyma into this. And one of the most common infection which cause the I would say the closed pneumothorax is tuberculosis in our country. Tuberculosis will cause the and second one is the COPD, and the formation of the emphysematous bulla will cause this condition. It's probably. So it is the commonest one in this case. And the other one which I said it is a suction type, maybe possibility where it is called the valvular type of the pneumothorax, in which the air is entrapped during inspiration and it will not go out in the expiration, like the formation of a fistula type of a thing between the pulmonary parenchyma and the pleural space. Again, it is the bronchopleural fistula which causes this type of a problem, its possibility. Another which is common, which is question asking in the examination, is that which is the commonest cause in the recurrent type of the closed pneumothorax. Recurrent. Where recurrent is concerned, it is the non-healing of the tuberculosis. In case of the HIV, the recurrent pneumothorax are noted. In case of the Marfan syndrome, it is noted. recurrent. You close, you manage it, and then recurrent occur many times in a year, and that is a problematic for the physician. And in COPD also causes the recurrent type of the pneumothorax. The open pneumothorax is the invasive pleural and the pleural procedures which you are doing outside the chest wall. Chestoma, fracture of the ribs, it is penetrating into the pulmonary parenchyma and making a communication. So these are the this is the open type of the pneumothorax. It is called the spontaneous pneumothorax, the closed pneumothorax, valvular pneumothorax, and open pneumothorax. The pathogenesis is the tendency of the lung to collapse is balanced in the normal resting state by the inherent tendency of the chest wall to expand outward, creating the negative pressure in the interpleural space. Because there is a potential space around the lung. If you inspire, it will become very narrow. If you expire, it will enlarge. It is a negative pressure which is creating in the pleural space. When the air enters the pleural space, the lung collapses. Definitely, it will push the lung, and atelectasis occurs. In simple pneumothorax, the intrapleural pressure is atmospheric, and the lung collapses up to 30% of the air. If it is entering into the lung, into the thoracic cavity, and 30% of the pleural space is occupied, it is 30%. It is called the simple pneumothorax. And more than that, it is definitely pathological, and it is more, important. It is a small pneumothorax. To me, less than 30% is the small pneumothorax. More than 30% is the large pneumothorax. In complicated, what is called is a tension pneumothorax. That is an important one. Now, it is a large amount of the air, actually continuing leak, increasing the increased positive pressure in the pleural space. The air is sucking inside. For example, in case of the valvular one, with a further compression of the lung, contralateral shifting of the mediastinum, and decrease in the venous return in this fashion, and the cardiac output because it is pressurizing on the muscle of respiration, that is diaphragm. And there is also the shifting of the trachea along with it. This is called tension pneumothorax. It is severe form of open pneumothorax or closed pneumothorax. Usually it is which I already mentioned out previously, that it is mostly commonly seen in cases of the valvular type of pneumothorax. Now, clinical manifestation, it may be sudden onset. Of course, somebody have got emphysema, emphysematous bullavas, their subpleural valves were there and they rupture. And then what happened? Dyspnea, because of the pressure on the lung, the forward vessel capacity is reduced. There is pain because there is pressure on the parietal pleura, which has got the nociceptors. Pain will occur and cyanosis. Trachea and the heart may be shifted toward the unaffected side. Hyperinflammation and reduced movement of the affected side. And respiratory distress with retractions. And there is decreased vocal frequency and vocal resonance. VR and the tactile vocal frequency will become reduced. Markedly decreased breath sound, you will not hear breath sounds. And there will be a tympanic percussion note. It is the same note which you have experienced in the percussion of the abdomen, where a lot of gases are in the intestine. And when the fluid is present, there is usually a sharply limited area of the tympani above the level of the flatness to the percussion. And this is hydropneumothorax, when the fluid is present. You can demarcate it that there is definitely what is called as the tympanic nodes suddenly changing to the dullness, or it is what is called the stony dullness of the notes, percussion notes. It is hydro and pneumothorax. So clinically, we examine this patient. Is in pain and respiratory rate is more. In summary, the TK may be shifted, and on the side affected side, you see that the movements are less and they are bulging, are part of the hemithorax, and you will find also there will be tenderness on that area. If you go for the percussion notes, it is hyperresonant super or tympanic in nature, and if you go for the tactile vocal fermeter, it is reduced, and then on auscultation there are hardly any breath sounds, and vocal fermeter is definitely reduced. Breath sounds are not usually audible. You do these tests, succession is flash, because there is, if there is evidence of the hydropneumothorax, there is some fluid is there. If you will jerk the patient on one side to the other side, splashing sound can be heard. Coin test, you will place one coin on the one side and then tap it, and on the other part of the stethoscope, on the other side, you can hear very clearly the sound. That is called the coin test. Friction test. And friction, if you move your hands and rub the area where the pneumothorax was there, and you will hear on the other side with the stethoscope, you will hear very clearly the frictional type of experience in the stethoscope. Although these tests are not done usually today, but they are very good in where there is no facilities of the X-rays and there are no facilities of the other lab facilities are there. For example, in cases of Tharparkar district of Pakistan, where the lack of facilities are there, you have to, 100% sure about your clinical examination. Because in the case of the tension pneumothorax, it is a dire medical emergency. The patient will die in 5 to 10 minutes of time. You have to do the procedure, some procedure to reduce the pressure. Diagnosis by the radiographic examination, clinical examination. Other than that is the radiographic examination, and with the possibility of the diaphragmatic hernia is being considered, a small amount of the barium may be necessary to demonstrate that it is not free here, but it is a portion of the gastrointestinal tract that is in the thoracic cavity. Now this type of the test is not done nowadays. Ultrasound can be used also. It can be the to establish the diagnosis because it is the sonographic picture rather is very different on this side. Of the air, only air is there. And it can also diagnose indirectly the hydropneumothorax. The treatment is at the extent of the collapse of nature, the severity of the alarm. The small pneumothorax, less than 5%, I will say 3%. But less than 5%, or even the moderate size pneumothorax in an otherwise normal child or the patient may resolve without a specific treatment. Small means that 5% in one area, another areas are involved, etc. I mean to say, in the whole, less than 30% will not cause any problem. It can reabsorb air itself in a due time. Needle aspiration is needed where there is tension pneumothorax, and primary spontaneous pneumothorax where the cause is not established. It may be genetic and familial in everything. We don't know. And there is a large amount of air is present. More than 50% of the, or 60% or more than that on that side, is pushing the mediastinum to the other side. It is compromising the cardiovascular system as well as the diaphragm is also will not work, so it is difficult for the respiration to maintain. If the pneumothorax is recurrent, secondary to the undertension, or there is a more than 5% collapse in the different areas, then you have to do the chest tube drainage. Because if it is definitely is going, the recurrency is there, so underwater seal is should be used. Pneumothorax complicating malignancy. Here, because there is repeated problem is going on, you have to close that hole which is present. For example, bronchopleural fistula or a foramen is present. Then the chemical pleurodesis means the agents will be induced by certain chemical agents. At one time, we were using the talc, and application of the talc on that area will cause inflammation, and inflammation will cause in the fibrosis, and fibrosis will close it. Or we go to surgical thoracotomy, open it, and then surgical repair should be done. The closed pneumothorax adequate to expand the lung is the more efficient, the closed one, where there is you have to do the expansion of the lung. That is the aim. Chemical pleurodesis recurrent pneumothorax introduction of the talc and the doxycycline, or it is the expired doxycycline actually, or iodoprodium into the breast. It will irritate the pleura, and it will cause inflammation, it will cause fibrosis. And thus, it will close it. Open thoracotomy, plication of the Mbbs and closure of the fistulas, stripping of the pleura and the basilar pleural abrasion, etc. These are the procedures done. We do it surgically. Stripping of and abrading of the pleura leaves raw inflamed surfaces that the heal with the sealing agents. In this fashion, it will close the entry of the air in the open thoracotomy. The video-assisted thoracoscopic procedures are concerned. Preferred therapy for the bulbectomy. A lot of blabs are there, subpleural blabs or impediments, bullous, pleural stripping, pleural brushing, installation of sclerosing agents. Less morbidity than with the open thoracotomy. It's a good procedure. You can record it and maintain it, and you can do many procedures with the video-assisted thoracotomy surgery is concerned. So these are the discussion which I have done as far as pneumothorax is concerned. It is enough for the final year students, as well as I think it is enough for the those persons who are appearing in the FCPS Part 2 examination in internal medicine. This knowledge is enough for them. And I have done the pulmonology. Previously I have done the cardiovascular system. And now I want to go for the nephrology and gastroenterology with hepatology. If the time allows me, I will go to the rheumatology as well, and hematology, infectious diseases, and the neurology, and some part of psychiatry. If the time allows me, I will go through. I want to do all internal medicine with the help of my this type of discussion, which is actually I am recording it. And although it is not a face-to-face type of lecture, and I don't know it is effective or not. I don't know about it, because you have not given any comment on it. Yet I have not received comments from the listeners. Even most of you don't bother to open it. But at one time you will consider that these are very important informations which I have given in these lectures. Time will come and prove it. Inshallah, you will see. Now, from tomorrow, I am now continuing with the nephrology, some part of nephrology. to clear the concept of the nephrology. Okay, until Allah Hafiz, wa ma alayna illa al-balagh. Assalamu alaikum wa rahmatullahi wa barakatuh.